Next presentation is analysis of Medicare payments for preoperative imaging prior to carotid endarterectomy, presented by Dr. Krishna Martinez-Singh and colleagues from Stanford University.
Hello all, my name is Krishna Martinez-Singh. Thank you for the opportunity to present our work. We have no financial disclosures or conflicts of interest. Healthcare spending within the United States continues to rise. In 2018, $3.6 trillion were spent, comprising 17.7% of the GDP. Previous attempts to curtail spending have focused on the need to reduce waste and specifically unnecessary diagnostic tests within healthcare, including imaging. For vascular surgery patients, a possible area of interest is preoperative imaging. Prior to carotid endarterectomy, a previous study found 46% of patients underwent duplex alone versus 43.9% with cross-sectional imaging. Current SVS guidelines do not make a strong recommendation for cross-sectional imaging, MRI or CT, prior to CEA. The objectives of our project were to describe trends in preoperative carotid imaging and associated clinical outcomes for patients undergoing CEA for asymptomatic carotid disease in the Medicare population. We also evaluated Medicare payments for pre-procedural imaging studies and evaluated inpatient hospital payments. In order to conduct our study, we started with a 20% Medicare claims file from 2006 to 2014 and used the ICD-9 code for endarterectomy, and selected for asymptomatic patients by excluding ICD-9 codes for TIA and prior CVAs. Beneficiaries to the physician carrier file were used to evaluate radiographic studies with CPT codes for carotid ultrasound, neck MRI, or neck CT. Payments were evaluated with outpatient and inpatient revenue files. Patient outcomes of hospital length of stay, postoperative stroke rate, carotid re-exploration rate, and mortality rate were obtained from the inpatient file and compared between the two groups. We identified 58,773 patients undergoing carotid endarterectomy for asymptomatic disease. 2/3 of those patients identified underwent CSI, compared to 1/3 who underwent ultrasound alone. With regards to patient outcomes, the median hospital length of stay was 2 days and was statistically significantly higher for the patients with CSI. Postoperative stroke rates were 0.38% and not statistically different between the groups. Carotid re-exploration rates were 1% and similarly not statistically significant between the groups. A total of 17,345 deaths, about 29.5%, were observed at a median of 2.9 years. Kaplan-Meier analysis was not statistically significant between groups during follow-up. The average preoperative imaging payments were lower for those with ultrasound alone, $329 compared with cross-sectional imaging of $802. Inpatient payments were also lower for patients with ultrasound alone, $7,143 compared with $7,792 for CSI. Multiple preoperative imaging studies with cross-sectional imaging for patients with asymptomatic carotid disease may result in significant economic burden without a clear, measurable benefit of patient outcomes. We acknowledge CSI may be utilized to evaluate patient anatomy and identify high-risk patients, and this data set may not capture all the benefits of preoperative imaging. We note that SVS guidelines do not have a strong recommendation for obtaining CSI. Rather than recommend for or against CSI, we hope this study makes surgeons more cognizant of preoperative imaging costs. As this study represents a 20% sample of Medicare beneficiaries, the cost savings of not using CSI is roughly $95 million over the 9-year period. We hope that as vascular surgeons, we all do our part to help curtail healthcare spending for our patients. Thank you very much.
Thanks. Very interesting talk. I see you removed your tie since your presentation, so strong work on that. Um, just a couple of questions while we're waiting for some more questions to come in from the crowd. How do you think that TCAR and its utilization recently is going to change this? Because most of us will obtain a CT scan in planning for TCAR just to see if it's usable for the patients.
Yeah, so that was sort of beyond the scope of our study. I know that, as sort of TCAR becomes more cemented in our daily practices, preoperative CTAs are going to be, imperative to preoperative planning. But, our sample was from 2006 to 2014. And so, we chose to look specifically at, carotid endarterectomies. But, we sort of recognize that people are going to be ordering more CTAs as more patients are eligible for TCARs. But I think the overall goal of the study was just to sort of make sure that people are cognizant of the costs of CTAs and what have you.
How many patients had both a duplex ultrasound and a CT scan? And conversely, how many patients had just a CT scan and no ultrasound?
So in terms of one second.
The question being basically, could this just be a marker basically of more anatomically complex, high distal disease that is giving us information at the extra cost? There's not going to be any difference in outcomes because we've identified the issues on CT scan, basically. I mean, how do you tease out those issues?
So for getting the CT scans, as compared to the ultrasounds, I think most of the people who did have the CT scans did undergo duplex. I think it was about 2.5 per person, which really just shows us that duplex is the preferred surveillance tool. And then, CTAs, what we sort of inferred is that it really comes down to regional differences, institutional preference and, physician preference. And so, the SVS guidelines do make a recommendation for obtaining CT scans. If you're concerned about, common or distal disease. But I think the overall goal is not to say don't get CTAs because they're driving up healthcare costs. I think we realize the utility in obtaining these pre-op CT scans, but and it's not needed in all patients. And what we're really trying to do is bring attention to the practice of everybody ordering a CTA before carotid, when in some situations it's not needed.
Did you have any information on the completion studies done in the operating room, whether it be an ultrasound or an on-table angiogram? Was there any difference in the patients that received a carotid CT scan prior to the procedure? And then on similar grounds, did you see a difference in follow-up studies? So did the patients that got CT scans preoperatively get CT scans postoperatively? Did you see any difference there?
Oh, that was something that I think is one of the biggest limitations of this. We weren't able to evaluate intraprocedural characteristics or, completion imaging. And so, our analysis ended at sort of the operation. We did not look at, who received what surveillance imaging post-op.
Great. In the interest of time, we'll move on to the next presentation. Great job.